All right, so today we're diving into something pretty crucial, especially if you're thinking about a career as an LPN, and that's malnutrition and obesity.
Yeah, two sides of a coin in a way.
Exactly. And we've got a great resource to guide us today, primarily pulling from Nutrition for Nursing, Chapter 12.
Definitely a go-to chapter for understanding the nuts and bolts of these conditions.
It is. And the goal today is to really break it all down, make it easy to remember so you can absolutely ace that LPN exam. But even beyond that, this stuff is so foundational for everyday nursing care, you know?
Oh, for sure. It's about connecting the dots between nutrition and how it impacts your patients, how you spot problems, and what you can actually do about it. That's what we're aiming for today.
Okay, so let's kick things off with malnutrition. Now, when you hear that word, what's the first image that pops into your head? I bet it's someone who's really thin, right?
Probably. Yeah, it's sort of the classic picture we have.
Totally. But our source is making a really important point here. You ready for this? Malnutrition isn't just about being underweight.
Ah, okay, yeah, I see where you're going with this.
It's broader than that. It's actually about not getting enough nutrients or having an imbalance, and here's the kicker. It can happen in people who are overweight or even obese.
That's such a good point. It really flips the script on how we typically think about nutrition.
It does, and that's why it's a super important concept to grasp, especially for your exam. It's not just about the number on the scale. You've got to look at the whole picture, the quality and balance of nutrients a person's actually getting.
Absolutely. And what's fascinating is how much of an impact malnutrition has. It's linked to higher rates of illness and death, lower quality of life, and a huge burden on healthcare costs. It really touches every corner of a person's health.
It really does. It can affect how their organs work, mess with their thinking, even slow down wound healing. Plus, think about the global picture for a sec. The WHO data, remember, shows that in a lot of countries, more deaths are actually linked to being overweight or obese than being underweight.
Yeah, that's a really interesting perspective.
It is. It makes you think about nutrition on a much wider scale. Now let's zoom back in and talk about how healthcare professionals actually diagnose malnutrition.
Right. How do they know for sure?
Well, the Academy of Nutrition and Dietetics, they've got a specific set of criteria, and it's not just one thing. It's a combination of different signs they're looking for.
Makes sense, like putting together puzzle pieces.
Exactly. So what are they looking for? Well, first off, of course, not getting enough calories. That's a biggie. But they're also looking for physical signs, like a loss of muscle mass and that fat under your skin, the subcutaneous fat.
Okay, yeah, those are visual cues.
They are. And then unintentional weight loss, that's a huge red flag. And they even look at functional status, like if someone's hand grip strength has gone down.
Interesting. So it's not just about how they look, but how well they're functioning too.
Exactly. And here's a tricky one, something to keep in mind for your exam. Sometimes weight loss can be masked by edema, so you got to consider that as well. It's about the whole picture, not just a quick glance.
Makes sense. It's like being a detective looking for all the clues.
Right. Okay, so now let's get into the different types of malnutrition. First up, protein energy malnutrition, or PEM. This is kind of the foundation, the basic category.
Quietly blocked out.
Exactly. So PE, you might also see it called protein energy undernutrition, and it basically boils down to a calorie deficit, not getting enough protein, carbs, and fat. Those are the main sources of energy, right?
Yep, the fuel our bodies need to run.
Exactly. Now, here's a little distinction that's important, especially for understanding the terminology. Our source makes a difference between starvation and PE.
Okay, I've always thought of those as pretty much the same thing. What's the key difference?
So starvation is the complete absence of nutrients, and a crucial point is that it doesn't involve inflammation. Now, PE is also a nutrient deficit, but it can occur in various situations, and sometimes, and here's the difference, alongside inflammation, particularly when there's some kind of underlying illness.
Oh, okay. So starvation is more of a strict definition, while PE is a broader category.
Exactly. And within PM, there are two main types you need to know for your exam: marasmus and kwashiorkor.
Ah, yes, those terms. Marasmus is the one where someone looks extremely thin and weak, right?
Got it. Marasmus is all about a severe lack of both calories and protein. And here's a key point from our source that might trip you up on the exam. Serum protein levels could actually be normal.
Really? Even though they're clearly wasting away.
Yeah, it's because the body is basically breaking down its own tissues for energy, including muscle. It's a survival mechanism.
Wow, that's intense. So then what about kwashiorkor? I remember that one being linked to a swollen belly.
That's right. Kwashiorkor often involves a lack of protein or maybe getting enough calories, but the protein quality is poor. That's the main thing to remember for your test. Because of the protein deficiency, serum protein levels are typically low, and that edema, yeah, the swollen belly, that's a classic sign.
So with kwashiorkor, even if they're getting enough calories, it's the lack of protein that's causing the problems.
Exactly. That protein piece is super important to remember. It's the key difference between the two.
Got it. So PEM, two types, marasmus, severe lack of calories and protein, and kwashiorkor. Primarily a protein issue, even if calories are okay.
Nailed it. Now let's move on to the next category, chronic disease-related malnutrition. This is super relevant for your future as an LPN.
Yeah, I can see why chronic illnesses are so common.
They are. So this type of malnutrition develops when people have these ongoing health conditions, and one of the main things at play here is inflammation. Even mild to moderate inflammation can mess with someone's appetite and make it harder for their body to use nutrients properly.
So it's not just about what they're eating, but how their body's handling it.
Exactly. And our source has some really good examples here that you should know for your exam. Chronic alcohol use disorder, COPD, cystic fibrosis, and chronic kidney disease.
Okay, let's break those down. First up, chronic alcohol use disorder. What are the main concerns there?
Well, first off, poor diet is super common. And then there are often liver problems that interfere with how the body absorbs and uses nutrients. The source specifically mentions that many people with this condition might need multivitamins and other nutritional supplements. And a big thing to remember for your exam is the risk of alcoholic encephalopathies, which is basically brain damage caused by a lack of thiamine. And if someone has cirrhosis, they're likely deficient in those fat-soluble vitamins, A, D, E, and K. Oh, and don't forget, the ascites and pain from liver disease can make it really uncomfortable to eat.
So with alcohol use disorder, you're dealing with both poor intake and problems with absorption.
Exactly. It's a double whammy. Now, what about COPD? How does that mess with nutrition?
COPD makes breathing so much harder, right?
It does. And that means they're burning more calories just to breathe, which can lead to muscle loss and weakness. They often have no appetite, feel nauseous, get bloated easily, and might even get really short of breath while eating.
It sounds like it would be exhausting to eat.
It is. And then there's cystic fibrosis. What are the big challenges there?
Cystic fibrosis primarily affects the pancreas, right?
It does. And that means they have trouble absorbing fat, which can lead to deficiencies in vitamins A, D, E, and K, those fat-soluble ones. And just like with COPD, that extra effort to breathe really ramps up their calorie needs. Plus, they often have a distended abdomen and might experience GERD, which makes eating even more difficult.
So again, you've got the issue of not getting enough in, and then the body having trouble absorbing what it does get.
Exactly. And finally, chronic kidney disease. What are the things to keep in mind there?
With kidney disease, you've got the risk of uremia and electrolyte imbalances. And their protein and calorie needs get really individualized depending on their body composition and their lab values.
It's all about fine-tuning it for each person.
Totally. And here's a curveball for your exam. In the early stages of kidney disease, they often restrict protein to protect the kidneys. But once someone's on dialysis, their protein needs actually increase.
It's not a one-size-fits-all approach.
Definitely not.
Okay, so we've covered the chronic conditions. Now, the last category is acute disease-related or injury-related malnutrition. This one can come on pretty suddenly.
So this is more like when someone gets really sick or injured.
Exactly. Think major infections, trauma, critical illnesses, even if they were perfectly healthy and well-nourished before. The main culprit here is severe inflammation, which tanks their appetite and throws off their digestion and absorption. And sometimes, if their gut's not working, they might need TPN, total parenteral nutrition.
Okay, so that's bypassing the gut entirely and going straight into the bloodstream.
Exactly. Now, this type of malnutrition, it's not something to take lightly. It's linked to higher death rates, longer hospital stays, and soaring healthcare costs.
Whoa, that's serious.
It is. So the goals of nutritional support in these situations are really important. They're trying to prevent infections, get people off the ventilator faster, and shorten their stay in the ICU. Every bit counts.
Makes sense. So how do they typically provide nutrition in these acute situations?
Well, our source emphasizes a specific order. If the patient can eat, an oral diet is always the first choice. If that's not enough, then they go for enteral nutrition, EM, that's feeding directly into the gut. And that's preferred over parenteral nutrition, PN, the IV route, as long as the gut's working okay. And of course, they have to figure out individual fluid needs, factoring in things like blood loss, diarrhea, vomiting, fever, wound drainage, all that.
Sounds like a lot of careful calculations.
It is. They also have to determine calorie and protein needs. How do they do that? Well, indirect calorimetry, IC, that's the most accurate way. But if that's not available, they use weight-based formulas, and the specific calorie range depends on the patient's BMI.
Okay, so BMI comes into play here too.
It does, and the source makes a good point about protein. In acute illness, getting enough protein might be even more important than total calories, and again, the recommendations are based on BMI. They also mention that high doses of certain vitamins and minerals, like C, E, selenium, zinc, and copper, might be helpful.
Okay, so lots of factors to consider. The source then dives into some specific examples: burns, sepsis, and multi-trauma. Let's talk about those. First up, burns. What are the key things to know for the exam?
Burns are tricky because they massively increase calorie and nutrient needs. The body's in overdrive, trying to heal and rebuild tissues. If the burn area is small, less than 20% of the body, they might be able to get by with high-calorie, high-protein foods and supplements. But if they're not eating enough, like less than 75% of what they need for more than 3 days, they might need supplemental EN. And here's a key point. Starting EN or PN early, within 4 to 6 hours of the injury, that's linked to lower infection rates and better gut function.
So early intervention is key.
It is. And keep in mind that burn patients might have a high metabolic rate for a while, even after the initial injury.
Got it. What about sepsis? What are the main points there?
For sepsis, they use either indirect calorimetry or those weight-based equations to figure out calorie needs. And just like with burns, they start EN or PN ASAP if the gut's not working.
Okay, makes sense. And last but not least, multi-trauma patients. What are the nutritional considerations there?
Multi-trauma, think big accidents, multiple injuries, lots of inflammation. Their prealbumin and albumin levels often drop, and if they have a head injury, they're considered to be in a catabolic state, which means their body's breaking down tissues. And if they need enteral feeding, they use an oral feeding tube, not the one through the nose, especially if there's a skull fracture. Oh, and even after they come off the ventilator, they might still struggle to eat enough, whether it's because of dietary restrictions, being NPO for tests, or just feeling too nauseous or tired.
So many factors to consider.
There are. It's like a whole body puzzle.
It is.
Yeah.
And speaking of the body, let's talk about the complications of undernutrition. Our source really lays it all out, how it affects every single system. This is something you definitely want to know for your exam.
Okay, hit me with it. What are the big ones?
Well, for the heart and lungs, you can see decreased cardiac output, meaning the heart's not pumping as well, and decreased vital capacity, meaning their lungs aren't holding as much air.
So their breathing and circulation are compromised.
Exactly. Then, with the endocrine and immune systems, you might see cold intolerance, a higher risk of infections, and problems with protein synthesis, which means the body can't build and repair tissues as well.
And what about the gut? That's where a lot of these problems originate, right?
It is. Undernutrition can cause vomiting, diarrhea, loss of appetite or anorexia, poor absorption or malabsorption, and of course weight loss. And it doesn't stop there. It also affects the muscles, nerves, and even the brain. You might see reduced activity tolerance, decreased muscle mass, which is called cachexia, functional impairments, general weakness, and even a link to substance misuse.
Wow, it's really far-reaching.
It is. And even the skin can be affected. You might see poor wound healing, dermatitis, or just really dry, flaky skin.
So undernutrition is a whole body problem, not just about being thin.
Exactly. It's a vicious cycle. Poor nutrition leads to all these complications, which then make it even harder to eat and get the nutrients you need.
It's a domino effect. Now, the source also touches on the social determinants of health, those factors in someone's life that can contribute to malnutrition.
This is a really important aspect of care, understanding the bigger picture.
It is. And the source lists things like low income, lack of transportation, language barriers, lack of social support, low education levels, and even things like contaminated water sources.
All of those can make it incredibly difficult to get good nutrition.
They do. It's not always about individual choices. Sometimes the environment is working against them.
Very true. Okay, so we've talked about all the problems. Let's shift gears and talk about solutions. What does patient-centered care look like for someone who's malnourished?
Well, first off, the Joint Commission, TJC, they have a standard that every patient should be screened for malnutrition within 24 hours of being admitted to the hospital. Catching it early is key.
Makes sense. The sooner you intervene, the better.
Exactly. And treatment can involve a lot of different things, like adjusting their diet, giving them liquid supplements, multivitamins, correcting electrolyte imbalances, and if they can't eat enough, providing enteral or parenteral nutrition. It all depends on the individual and how well their digestive system is working.
So it's about finding the right approach for each person.
It is. Now, what about nursing actions? What are some specific things that you, as an LPN, would be doing for a patient who's malnourished?
Ongoing assessment is huge. You're documenting their appetite, weighing them daily, keeping track of their intake and output, monitoring labs like electrolytes, BUN, creatinine, CVC, liver function, albumin, and prealbumin.
Why is prealbumin particularly important?
Good question. Prealbumin is a more sensitive indicator of recent nutritional status. It has a shorter half-life than albumin, so it gives you a better snapshot of what's been going on in the past few days.
So it's a more up-to-date measure.
Exactly. Now, another important thing to know, especially for your exam, is refeeding syndrome.
That sounds scary. What is it?
It's basically a metabolic freakout that can happen when you reintroduce carbohydrates too quickly to someone who's been severely malnourished.
What happens exactly?
Well, the carbs trigger a surge of insulin, which increases the body's demand for certain nutrients. This can lead to a thiamine deficiency and cause electrolytes like potassium, phosphate, and magnesium to shift from the blood into the cells, leading to dangerously low levels in the blood.
Sounds like it could be life-threatening.
It can be. They might need thiamine and electrolyte supplements, and if they're on EN or PN, they might need to slow down the rate at first.
So slow and steady wins the race.
For sure. Now, in terms of general interventions for malnutrition, it's all about teamwork. You'll be working closely with the doctor, the dietitian, maybe a pharmacist to address medication interactions, and possibly a social worker or case manager if there are social issues contributing to the problem.
So it's a multidisciplinary approach.
It is. And of course, patient education is a big part of your role, teaching them about good nutrition, helping them choose healthy foods, and explaining any potential drug-nutrient interactions. You might also be involved in implementing enteral or parenteral nutrition if they can't eat enough by mouth.
It's about supporting them in every way possible.
Absolutely. The source even gives some practical tips for boosting calorie and protein intake, like adding butter or honey to foods, incorporating cheese and peanut butter, things like that.
Simple but effective.
Exactly. Now, the source also talks about some specific nursing actions to make eating easier and more enjoyable.
This is all about creating a positive experience, right?
It is. So, you want to manage their pain before meals, minimize strong odors, reduce noise and distractions, make sure the eating area is clean and pleasant, help them with hygiene before meals, and get them into a comfortable position, preferably sitting up. You also want to encourage them to use any assistive devices they need and minimize interruptions during meal times.
It's about making it as stress-free as possible.
Totally. You also want to make sure their food and drinks are at the right temperature, encourage them to feed themselves if they can, give them enough time to eat, and, of course, document everything.
Okay, so we've covered a lot of ground with malnutrition. Let's switch gears and talk about the other end of the spectrum. Obesity.
Okay, bring on the big O.
So our source defines obesity as a chronic condition where calorie intake exceeds calorie expenditure, and it's not just about willpower. It's influenced by all sorts of factors: genetics, environment, culture, socioeconomic status, and even the body's own mechanisms.
Right, I've heard that the body can actually try to resist weight loss.
It can. When you restrict calories, the body might release hormones that increase appetite to try and maintain a certain weight.
So it's a complex interplay of factors.
It is. Now, when assessing for obesity, what are some of the things healthcare providers will be looking at?
Well, they'll definitely be listening to the patient's experience. Are they feeling depressed, struggling with self-esteem, avoiding healthcare appointments, lacking motivation to exercise, or feeling anxious about their weight?
Those are important clues.
They are. And objectively, they'll be using BMI categories. Overweight is a BMI of 25 to 29.9, and obese is 30 or higher. They'll also measure waist circumference. For men, a waist circumference greater than 40 inches is a risk factor, and for women, it's 35 inches.
Okay, so those are some specific numbers to keep in mind.
They are. They also look at the waist-to-hip ratio, which can be a predictor of heart disease and an indicator of central obesity, where fat is stored around the organs. And they might order lab tests to check for things like high cholesterol, high triglycerides, high blood sugar, fatty liver disease, and thyroid problems.
It's about looking for those associated conditions.
Exactly. Now, just like with malnutrition, obesity is linked to a whole host of complications.
It's not just a cosmetic issue.
Definitely not. So, here we go. Cardiovascular and respiratory complications can include coronary artery disease, hypertension, hyperlipidemia, asthma, and obstructive sleep apnea. Endocrine and immunologic complications can include prediabetes, type 2 diabetes, non-alcoholic fatty liver disease, increased risk of infections, poor wound healing, and even certain cancers.
Wow, that's a lot.
It is. Then you've got GI issues like GERD and gallstones, musculoskeletal problems like osteoarthritis, neurologic issues like stroke, psychiatric and psychological impacts like depression, low self-esteem, social anxiety, and avoidance, reproductive and genitourinary problems like polycystic ovary syndrome, hypogonadism, and urinary incontinence. And there's an increased risk for complications during surgery and pregnancy.
It really affects the entire body.
It does. So what are the main interventions for obesity?
Well, the foundation is a reduced calorie diet. They might recommend healthy eating plans like DAAH, Mediterranean, or vegetarian, aiming for a calorie deficit of 500 to 750 per day. There are also very low-calorie diets, but those are usually only used under medical supervision in specific situations.
Okay, so diet is key. What else?
Physical activity is super important, focusing on reducing sedentary time and increasing both aerobic exercise and strength training.
So moving more and sitting less.
Exactly. And behavior modification is also crucial. This involves things like setting realistic goals, identifying and avoiding triggers for unhealthy eating, joining support groups, using behavior contracts, managing stress, and using motivational interviewing techniques.
So it's not just about willpower. It's about developing healthy habits and coping mechanisms.
Exactly. And in some cases, medications might be used, especially for people with a BMI of 30 or higher without complications, or a BMI of 27 or higher with at least one weight-related health problem.
Okay, so medications can be a tool in the toolbox.
They can, and the most effective approach is considered to be interprofessional care, involving a whole team of specialists, doctors, nurses, dietitians, social workers, maybe even a surgeon, and mental health professionals.
It's a team effort.
It is. And for some people, bariatric surgery might be an option, but this is a big decision, and there are specific criteria based on BMI and health conditions.
Right, it's not for everyone.
It's not. And it's important to remember that bariatric surgery works best when combined with diet and lifestyle changes, and it often requires ongoing monitoring and nutritional counseling. There are a few different procedures, right?
There are. The source mentions adjustable gastric banding, Roux-en-Y gastric bypass, and sleeve gastrectomy.
Can you explain those briefly?
Adjustable gastric banding involves placing a band around the upper part of the stomach to make it smaller. The Roux-en-Y gastric bypass is more complex. It involves creating a small stomach pouch and rerouting the digestive tract to bypass a large portion of the stomach and small intestine. And sleeve gastrectomy involves removing a portion of the stomach to reduce its size.
Okay, so those are some of the surgical options. And what about nursing care for obese clients? What are some key things to remember?
The source specifically mentions maintaining a low Fowler's position to help with breathing and providing education about their prescribed diet.
Okay, so those are some practical tips. Wow, we've covered a ton of information today. We've really delved into both malnutrition and obesity, hitting all the key points from Nutrition for Nursing, Chapter 12, that you need to know for your LPN exam.
It's been a thorough deep dive.
It has. So to wrap things up, here's a thought for you to ponder as you continue your studies. We've seen how closely linked nutrition is to so many different health problems. So what are some proactive steps that you, as a future LPN, can take to prevent malnutrition and promote healthy weight in all the diverse patients you'll encounter?
It's about thinking beyond just treating the problem and focusing on prevention and overall well-being.
Exactly. Thanks for joining us on this deep dive. We'll see you next time.